Biarritz, heureux de retrouver le Pays Basque, retrouver nos amis, tous, et évidemment nos amis étrangers qui nous font l'honneur d'être à ce rendez-vous tous les 2 ans avec un programme qui est de plus en plus riche et qui l'a déjà été dès le départ. Moi, je suis convaincu, comme Marc, que nous allons avoir des sessions et des ateliers de grande richesse. De toutes les façons, comme dit ma mère, quand il y a de bons produits, on fait de bons plats. N'est-ce pas, Jean-Pierre? Voilà. Donc, on s'est donné pour principe et pour consigne d'être à l'heure. Et c'est comme ça que toutes les salles se rempliront, parce que le programme est chargé. Vous l'avez bien remarqué qu'on a commencé à 8h15, alors qu'il y a 2 ans, on avait commencé un peu plus tard. Et comme d'habitude, Marc fera tout, puis moi je ferai le reste. On est d'accord. Vas-y.
Et donc, sans plus attendre, j'appelle le premier orateur, Reem SMOUM JAOUNI, qui va nous faire une présentation sur les cannabinoïdes, passé et perspective. SMOUM JAOUNI travaille dans une grande équipe à Jérusalem qui a extrêmement d'expérience de clinique et de recherche sur ce thème, donc on est très content qu'elle puisse intervenir. Chaque présentation sera suivie juste d'1 ou 2 questions, et si on a du temps à la fin, on pourra prendre des questions sur l'ensemble des présentations. Voilà. OK.
Good morning. Thank you for the invitation. I'm delighted to be here today. Today I'll speak about the cannabinoids, looking back and ahead. I'll give an overview of what has been done in our lab during the past few years. Okay, the plant Cannabis sativa, it has been long used for medical purposes throughout the history, and the first use was around 5,000 years ago in China, where they used the cannabis plant in order to relieve the pain and cramps. And Sir John Russell Reynolds has been quoted, he's a physician for Queen Victoria, and back in 1800, he was quoted saying that for the relief of certain kinds of pain, I believe, there is no more useful medicine than cannabis within our reach. And actually, the uses, or the well-documented uses of medical cannabis, it has been used as anticonvulsant, anti-inflammatory, anti-emetic, anti-nociception, as well as recreational use, which limited its application in the medical field. Now, the discovery of the endocannabinoid system, consisting of the ligands, the receptors, together with the enzymes that are responsible for the biosynthesis and degradation, this has prompted preclinical research with the aim of exploring the role of the endocannabinoid system in the health and disease. And there was a review in 2013 that said that modulating the endocannabinoid system activity may have therapeutic potential in almost all diseases affecting humans, including obesity, pain, diabetes, and so on. And we really hope that this is true. Okay. Over the last few decades, research on cannabinoids has gone through several distinct phases. We have the phytocannabinoid research, including research on THC and CBD, endocannabinoid research, including anandamide and 2-AG, and research on endocannabinoid-like compounds. Okay. Now, phytocannabinoids, these are natural compounds that are present in the plant itself. Now, the plant itself, it contains around 540 natural compounds, and of these, more than 100, they are considered to be phytocannabinoids due to their shared chemical structure. For example, we have cannabigerol, cannabidiol, THC, cannabinol, cannabichromane, and cannabicyclol. Now, most of the research has been done on 2 compounds, which are cannabidiol, CBD, and tetrahydrocannabinol, THC. And cannabidiol, it represents most of the, it represents about 40% of the extract from the plant resin. Tetrahydrocannabinol, it's responsible for the psychotropic effect of the plant. Just a quick overview of the uses of tetrahydrocannabinol, THC. Dorabinol is the synthetic form of THC, and it has been approved by the FDA for the use of as an appetite stimulant for the HIV patients, as antiemetic for the people receiving chemotherapy, Naboximols or Sativax, where the THC is the active ingredient, and it has been approved as well as a mouth spray for the multiple sclerosis symptoms, including pain, spasticity, and overreactive bladder. And THC as well has been known for its sedative properties and its use for anxiety. But its use for anxiety, it depends upon the dose. Low dose, it reduces anxiety, and high dose, it heightens it. However, the use of THC may cause psychotic attacks at very high doses. And there has been a preliminary clinical trial that has been done for people with PTSD, and it showed positive effects as well. However, of clinical importance is CBD, and it has been used as an anti-epileptic drug, and as well for many therapeutic areas, including autoimmune diseases, schizophrenia, cancer, bone fractures, and so on. Now, the use of cannabinoids for epilepsy, it has been long since the 1960s, 1970s. The THC and the CBD, they had showed very potent effect against epilepsy. And actually, back in the 1980s, there was a clinical trial that was done in Mashulam's lab together with collaborations in Brazil. And they found that 4 out of the 8 patients that received the CBD, they were almost free of seizures, and 3 patients had partial improvement. And therefore, 40 years from the time that this clinical trial was done, there was many controlled clinical trials that proved the effect of the CBD for epilepsy. And in 2018, the FDA approved Epidiolex for the seizures that was associated with 2 forms of epilepsy in children 2 years and younger. As for type 1 diabetes, as we know that type 1 diabetes is an autoimmune disease. It is characterized by high blood sugar, and this is because the body can create insulin because of the destruction of the beta cells. And we tested CBD, and we found that it reduces the incidence of the type 1 diabetes from an incidence of 86% in the non-treated controlled mice to incidence of 30% in the CBD-treated mice. And this is because CBD preserves the beta cells from the destruction. As well, bone fractures. Bone fractures, they are highly prevalent and involving prolonged immobilization and discomfort. And bone healing, it includes 3 stages that are overlapping. The first stage is the inflammatory stage, which is the development of the hematoma. The second stage is the repair stage, where the fibroblasts, they form a stroma, which support the vascular ingrowth. And the last stage is the bone remodeling, where the healing bone gets its structure and strength back. And what we saw is that CBD, it induced the enhancement of the callus strength and toughness through the effect on the osteoblast cells, and it increased the collagen cross-linking as well. And finally, I would like to mention the effect of the CBD on cancer. Neuroblastoma is a childhood cancer that affects the children 2 years of age and younger. And what we found is that the CBD, it reduced the viability and effectiveness of the treated tumor cells. And as well in vivo, it reduced the volume of the tumor in the mice. Now, coming to the endocannabinoids. the endocannabinoid system, it consists of the endocannabinoid ligands, it consists of the endocannabinoid receptors and the enzyme transporters. And actually, from the time that THC was discovered in 1964, in the 1990, the first receptor was discovered. It is the receptor in which the THC bind to it. It is called the Cannabinoid One Receptor. It is expressed in the central nervous system and peripheral nervous system. And we have later, there was discovered the Cb2 receptor. This was expressed on the immune cells, and therefore it gives protective effects. Actually, there are other receptors in which there are targets as well for the endocannabinoids and endocannabinoid-like compounds, but they are not really considered of the endocannabinoid system, but we put them as targets for endocannabinoids. These are G-orphan coupled protein receptors, GPR55, 18, 119. We have the ion channels, we have the PPAR receptors. As well, 30 years after the discovery of THC in 1964, there was the first endogenous lipophilic molecule that was able to bind to the receptors that were targeted by THC was discovered. And the first compound that was discovered was anandamide. And later after the discovery of anandamide in 1992, another important endocannabinoid was discovered, which is 2-AG, 2-arachidonyl glycerol. And other omega-6 fatty acid compounds that had cannabimimetic properties, they were listed among the endocannabinoid family as well. This includes the virodamide, NADA, and noladine ether. In the family as well of the endocannabinoid system, we have the enzymes that are responsible for the degradation and for the biosynthesis, as well as for the transport of endocannabinoids. Now, the endocannabinoids research, these compounds, they were tested for a lot of diseases, and they actually had a great efficacy in all of these. And I would like to mention something about traumatic brain injury. These compounds, we work with Professor Esti Shohami that's working on TBI. And in a mouse model of closed head injury, we found that if the mice, they were exposed to traumatic brain injury, then the amount of 2-AG, the anandamide 2-AG, it's elevated after 1 hour. It peaks to 10-fold increase after 4 hours. So why there is elevation in the 2-AG? And actually, we found that if we give 2-AG to the animals that they are traumatized, the 2-AG attenuated the neurological deficits, edema formation, infarct volume, and blood-brain barrier permeability. So when there is brain injury, what's happening is that the release of all harmful mediators in the brain. And these harmful mediators, they result in neuronal and glial cell death and in cerebral ischemia. Once this happens, there is on-demand release of the endocannabinoid 2-AG. And this 2-AG, it can work as an antioxidant. It can inhibit the production of inflammatory cytokines, and it will act as a vasoconstrictor, as a vasodilator, actually. So, however, 2-AG is not very much effective in doing this. There are other endocannabinoid-like compounds that are released, and these endocannabinoid-like compounds, they resemble anandamide in their structure. They bind very weakly to cannabinoid receptors 1 and 2, or TRPV1. However, their action is actually inhibited by CB1 and CB2 antagonists. So they are considered to be endocannabinoid-like compound. And of these, we have anandamide and arachidonyl glycerol. They are the main endocannabinoid compounds. And we have arachidonyl serine, which is an endocannabinoid-like compound. We have isolated this in our lab from bovine brain. And as I said, it binded very weakly to CB1 or CB2. Now, the effect of arachidonyl serine on traumatic brain injury was the same as 2-AG. However, it was much more effective. It was a vasodilator and a neuroprotective. I would like to mention as well the effect of endocannabinoids and endocannabinoid-like compounds as antimicrobial compounds. These molecules, they have a lot of effectiveness, and as I said, one of them is the antimicrobial potential. What's happening is that the bacteria, they communicate with each other through quorum sensing, and bacteria attach themselves to surfaces using this quorum sensing. And when they attach themselves to surfaces, they form bacterial biofilms. And bacteria inside the bacterial biofilms, they are 10 to 1,000 times more resistant to antibiotics than the bacteria in their planktonic state. So we took a kind of bacteria, which is the methicillin-resistant S. aureus. This is a kind of bacteria that is responsible for hard-to-treat infections, and it forms biofilms in the implanted medical devices, such as catheters, and as well on necrotic tissues in wounds. So what we found is that the endocannabinoid anandamide, it inhibits actually the quorum sensing. It inhibits the gene expression, which is responsible for the quorum sensing and the motility of the bacteria. And as well, anandamide and arachidonyl serine, they dose-dependently inhibit the biofilm formation and the aggregation of the bacteria. As well, the effect of these compounds on osteoporosis. Now, one of the causes of osteoporosis in women is the estrogen loss during menopause. So our mouse model, we take the mice, we remove the ovaries. After we remove the ovaries, there is bone loss. And 6 weeks after this, or from the time of removing the ovaries till 6 weeks, we wait 6 weeks, and from then we give our compound, and our compound proved to be effective in reducing the bone loss. So what we can see is that the vehicle-treated mice lost more than 50% of its bone loss, and then oleal serine, which is an endocannabinoid-like compound as well, it saved by around 50%. It saved this bone loss. Now, finally, I would like to mention something about the Cb2 receptors. As I said, the Cb2 is the second receptor that was discovered, and it is expressed on the immune cells. Cb2 is expressed in the immune system, and it has therapeutic potential in inflammatory, fibrotic, and neurodegenerative diseases. And the same Cb2 agonists, they were tested for heart failure, atherosclerosis, spinal cord injury, liver fibrosis, and in all of these agonists, they proved to be effective. Now, in our lab, we synthesized some of the compounds that proved to be potent selective Cb2 agonists. They do not have any psychotic effects. And actually, the 308 and the 910, these are compounds that were selected in a recent review as the best Cb2 agonists to study the effect of the Cb2 in health and disease. And what we found is that the 433, this is a compound that binds to the CBT in the nanomolar range, CB2 in the nanomolar range. This compound, it inhibits inflammation, and it reduced the osteoporosis, the OVEX-induced bone loss. In addition, we have HU 910 and HU 914, and these compounds, it induced neurobehavioral activity and inhibition of the TNF-alpha. So it was against inflammation, and it was neuroprotective. So to summarize, the endocannabinoids, they are involved in a large number of physiological processes, and THC, this is a plant cannabinoid, it mimics their action. The CBD derivatives, they may lead to a wide spectrum of novel drugs. The fatty acid, amino acids, and derivatives, they may lead to better understanding of biological processes, as well as novel drugs. And the CB2 specific agonists, they may lead to a wide spectrum of protective effects in the diseases. And finally, I would like to thank all our collaborators at the Hebrew University, Professor Esti Shuhami, who worked on TBI, Ruth Galili, who worked on diabetes, Steinberg, who worked on antimicrobial effect, and the late Professor Etai Bab, who worked on osteoporosis. And of course, Jan Kalgebet and Professor Aaron Toran, who worked with cancer. And thank you for your attention.
Thank you very much. Je vous propose, pour qu'on puisse avoir la possibilité d'être dans les temps, bon, on a décidé de manière un peu collégiale, ça ira à deux, de prendre des questions à la fin. Ça sera plus simple parce qu'on va avoir des interventions qui probablement appelleront à des recoupements. Donc, on va se donner du temps. OK? Thank you very much. We're going to give you the question at the end. OK?
Thank you.
Alors, on va poursuivre. Je me lève.
On va poursuivre avec quelqu'un que nous connaissons bien, qui est un habitué de THS. C'est le professeur Yvan Montoya, qui est un ami évidemment du Pays Basque et de la France en général, et qui est de manière très amicale, vient régulièrement nous donner un peu la température de ce qui est tendance et ce qui est en train de se mettre en place dans le monde de la pharmacopée. Et cette fois, donc, il va nous faire un état des lieux des traitements des troubles de l'usage de substances. Et je vous invite à noter ce que Yvan nous dit, parce que très souvent, quelques années plus tard, on va arriver, évidemment, soit des médicaments, soit des recommandations. Thank you very much, Yvan.
Thank you. Well, first of all, thank you so much for the invitation to this conference. This is now, like, I think my third time attending this conference. It's great to be here in this beautiful city. And so what I have two presentations this morning, and I broke them into two different areas. So the first part is I'm going to give a brief overview of the pipeline of medications that are being tested for stimulant use disorders in the first presentation. And then the second presentation, I'm going to talk about more on opioids, because that's a new program at NIH and is quite large, and I think it deserves a little bit of a special attention. So my first presentation is about the med development and for cocaine, methamphetamine, and cannabis. Those are programs that have been in place at NIDA for many years. I have been at NIDA for 30 years now, and we started doing medications development for cocaine dependence during the epidemic of cocaine in the late 80s and 90s, and we're still doing a lot of research. And for a while, because of the opioid crisis, the relevance of cocaine and methamphetamine was kind of overlooked, although there was a little bit of a reduction in the use. But what we are seeing right now is a resurgence of both cocaine and methamphetamine. So this is the prevalence of cocaine use in the last year. This is from 2002 to 2018 in the United States. This is data from the National Survey on Drug Use and Health from 2018. This data was released very recently. And as you can see, there was a certain decrease in the 2010, 2011, and then you can see here it is increasing since 2013 approximately. And this is the number, the people that have received treatment for cocaine use disorder. So there's been, instead of increasing, there has been a decrease from 2017 to 2018. I wish I had data from the previous years, but unfortunately the data from this survey was not comparable for the previous year, so I only have the data for 2017 and 18. But this is an important information. Why? Because although we see that the problem is increasing, the number of people seeking treatment is decreasing. And there may be two reasons that I can think of. One is that perhaps the risk of the drug, the perception of risk of the drug is decreasing and people don't feel like there is a need to go to treatment. Or the other possibility is that people realize or people think, well, treatment doesn't work. There are so many medications that have been tested for cocaine use disorders that basically is not worth even trying to go to treatment and looking for a medication. So those are hypotheses to be tested, but in any case, this is the reality. And this is the reality also for methamphetamine. So actually, for methamphetamine is even more dramatic because we can see 2015. Again, data prior to 2015 for methamphetamine is not comparable, so I took the data from 2015 to 2018 that was published in the National Survey of Drug Use and Health, and I plotted it, and I was surprised when I saw this dramatic increase in methamphetamine use from 2015 to 2018. And the same thing that we saw with cocaine is a decrease in the number of people that are being seeking for methamphetamine use disorders. For none of those disorders, there is any medication approved by the FDA for the treatment of the disorder. So although we have been looking at basically anything that can be investigated for those disorders, there's right now no medication approved that physicians can prescribe and that has been approved by the FDA for those disorders. So this is also, as I said before, in part the reason why we see this decrease in the number of people seeking treatment. Now, the most concerning part of all, you probably have seen this figure. This is from the Center for Disease Control, and this is the number of people dying from overdoses in the United States. And perhaps you have seen this picture before because of the dramatic number of people that have been dying from synthetic overdoses. And I presented some of this data in this Congress before. About 30,000 people died in 2017 from basically from fentanyl overdoses, and then about 15,000 from heroin. And I'm going to come back to this figure in my next presentation. But why I'm bringing this figure here is to look at the number of people that are dying from cocaine overdoses. Approximately 14,500 dying from cocaine overdose in 2017. And from methamphetamine, about almost 11,000 people dying from overdose. So those also increases correspond to what I showed before of the increases in drug use since 2013. So what we are thinking right now, at least at NIDA, we are considering the possibility that we are seeing a new epidemic of stimulant use disorders, basically from cocaine and methamphetamine. And unfortunately, and what I'm going to present this morning is that, as I said before, we don't have any medications approved by the FDA for those disorders. But what the medications that we are testing, we are far from getting anything approved yet. And I mean, that's kind of like very bad news and concerning news, but we are trying, we are now, this is like a wake up for us at NIDA, and now we are going to be focusing more and more on looking at more medications to treat those disorders. So this figure, you probably have seen it in many presentations before. This is a system, is a schematic view of the neurobiology of stimulant use disorders. And usually the biggest culprit in this is dopamine, but there are many receptors and many transmitters that have been involved in the reward system, and from GABA to opioids to many other receptors. And all of those receptors, basically all those targets have been tested, and again, nothing has been demonstrated to be efficacious for those disorders. But let me tell you a little bit about what we are doing in terms of the clinical studies. And those are the candidates that we have in our pipeline right now for cocaine. One is the 5-HT2C agonist lorcaserin. Lorcaserin is approved in the United States for treatment of obesity. It's called Belvic. We are very interested in orexin 1 antagonists. I'm going to present some data with an orexin 1 antagonist that is being tested. This is a compound that is being tested, but right now is in a phase 2A study. It's an Embera 1-on-1. It's a combination of oxazepam and metyrapone, but there's not. It doesn't seem to have a path forward. So I'm not going to discuss it other than to say that it is in phase 2. As you probably have heard from many presentations in the past, there was a lot of interest on buprenorphine because of the kappa antagonist effects of buprenorphine, perhaps combined with an opioid antagonist to exhibit more kappa antagonist effect with the possibility of treatment for cocaine use disorders. There's some data that is promising, but Ackermis, the company that was studying this combination, doesn't seem to be very interested in moving forward with this compound. The other one that is kind of interesting is ketamine. It's an anesthetic, as you know, and it produces a dissociative anesthesia, and it's being tested as an adjuvant for more like a mindfulness type of behavioral intervention because it produces some experiential effects, and it's being tested, and the data right now seems quite promising. The other compound that is also approved and is being tested is oxytocin. It's a hormone that is apparently associated with improving interpersonal relationships, and is also being tested in phase 2 studies. And the other one is, the final one is, this is a L-tetrahydropalmitin, or LTHP. This is an abbreviated name. It's an extract from a plant in China. We supported the development of the preclinical studies, went through IND, and it went through phase 1, but it's now, it went through a phase 1 study, and the phase 1 study didn't show much promising, so we are not right now very invested in moving forward with this compound. However, if we feel that right now with this epidemic, we may be able to bring this compound again and see if we can test it in a phase 2 trial. So this is what we have right now for cocaine. And let me just talk about 2 of those compounds. The first one is lorcaserin, and this is not moving forward, and this is not good. I can keep talking without the slides, but I think it will be helpful to see the figures. Nope.
Les diapos sont coincés. Au secours.
In any case, so The serotonin receptors have been associated with reductions in cocaine self-administration and stimulant, in general, stimulant self-administration. And they have been tested not only for cocaine, but also for methamphetamine and even nicotine use disorders. And they have shown some efficacy. So NIDA got involved in conducting a very large multi-site clinical trial with lorcaserin for treatment of cocaine dependence. It's in multiple sites. And this is based on data that were from not only preclinical, but also from clinical data. And the data right now, well, unfortunately, the slide is not there, but it was very promising. As I said, it was a phase 3 clinical trial that we conducted with all the rigor required by the FDA to hopefully bring this compound for an IND for an NDA, sorry, for approval by the FDA. But unfortunately, the results have not been published, and I wasn't going to present any results, but it seems like the results are not very promising, and this is like news for you, for everybody. Again, it hasn't been published, but we are probably going to abandon lorcaserin for now. There is another study that is being conducted at UCSF, and it's a much smaller study in a sample of people who use, let's see. Okay, so this is some of the preclinical data with lorcaserin, and this is the study that I was mentioning before that was conducted by NIDA, and it's a multi-site, multi-center clinical trial in a sample of 272 subjects. They were treated with 10 milligrams BID for 13 weeks, and again, the data was analyzed, and the preliminary results don't seem to be very positive. So we are waiting for the final results, but so far we are not very enthusiastic about moving forward with this compound. So this was, again, the one that we have in the pipeline that we were very hopeful that probably was going to be an efficacious treatment. The other one I mentioned before is the study that is being conducted at UCSF, but it's a very small study in a sample of 45 subjects. We'll see what that study shows, and depending on that, we'll make the final decision if we continue moving forward with lorcaserin or not. The other target that is of great interest is the Erection System, or the hypocretin system. This is a system that is very ubiquitous in the brain, and there are only very few neurons that are involved in the system. There's only about 10 to 20,000 neurons in the human brains, but they have many projections, and they are going to many areas that are associated not only with drug use problems and reward, but also with sleep and anxiety. So there are two types of orexin receptors, orexin 1 and orexin 2, and they are associated with arousal, wakefulness, reproduction, appetite, and the reward system, as I mentioned. So why orexin antagonists for cocaine? Well, they reduce the dopamine transporter sensitivity. They disrupt the expression of associations formed by cocaine. They reduce the compulsive-like cocaine undertaking under self-administration conditions, reduces motivation to obtain cocaine, and reduces the strength of cue and stress content-induced cocaine reinstatement. So those are pretty good reasons to be tested. In addition, clinically, because the orexin 1 antagonists are very good for sleep, and actually there is one approved in the United States. It's called suvorexant for treatment of sleep disorders. It's not a sedative. It is what is being claimed for this compound is that it improves the sleep architecture. So it's not like the patient feels sedated, but it sleeps well. So that's a big difference. And because most of the patients with substance use disorders have sleep problems, and not only that, sometimes sleep problems is what makes people use drugs, but usually when people are trying to stop their drug use, one of the biggest problems or the barriers to make them stop using drugs is because they have sleep problems and they relapse because of that. So sleep impairs modify the sleep-wake cycle, and drug withdrawal is associated with sleep disruptions, and we have many problems associated with sleeping comorbidity in people with substance use disorders. Unfortunately, that comorbidity is treated with benzodiazepines, and benzodiazepines, as we all know, can produce also addiction. So we think that perhaps orexin-1 antagonist, by improving sleep and by the effect by itself that has on the reward system, they maybe have a potential. So we are testing this suvorexant, that is the one that is approved in the United States. It's an orexin-1, orexin-2 antagonist. It's a Schedule 4 compound. Unfortunately, that's an issue, but it's approved for treatment of insomnia, and it's being tested at a dose of 10 milligrams versus placebo to reduce anxiety. It's a very small sample size, but again, it's one of the few studies that we have right now that is in the pipeline. And recently, Scott Lane at the University of Texas, they reported a study showing evidence favoring suvorexant for cocaine dependence because for improving inhibitory control, improving sleep, stress reactivity, and craving. Unfortunately, it was a very small sample size, and the study didn't show reductions in cocaine use. However, showing reductions or those changes may have some promise. And as I said before, given the lack of promising medications, this is something that we may be interested in moving forward and pursuing in the near future. And there's also right now a human lab study that is being conducted by Bill Stoops, and we hope that that study also will show some of the same effects that Scott's study show, and we can hopefully move forward with this compound. Now, for methamphetamine, the pipeline is much smaller than for cocaine because NIDA started the cocaine, the methamphetamine medications development program more recently. It's about 20 years old, and the cocaine is about 30 years old. But with this one, we also have the same experience, no medication approved, and many medications have been tested, less than for cocaine, but still less medications. Now, this is the pipeline that we have right now. In that pipeline, we have the first one that is kind of like the most promising, is mirtazapine, and I'm going to discuss a little bit more about it. There's a monoclonal antibody, and I'll present about it. It's a vaccine, and there's some other medications that have also been tested, but we're waiting for results, and we'll see what's going to happen with those medications. Now, mirtazapine is kind of interesting because it's a potent antagonist or inverse agonist of the adrenergic A2A receptors and 2B and the A2C receptors, and it also works on the serotonin receptors and the histamine receptor. Sorry. And doesn't inhibit the reuptake of serotonin, dopamine, or norepinephrine, nor does it inhibit monoamine oxidase inhibitor properties. So it is safe, it doesn't have abuse potential. However, it produces somnolence, weight gain, and dry mouth. It may reduce methamphetamine craving. And this is data that was published from the study that was an early, not relatively, was a study that was done in 2005, but it's showing that comparing mirtazapine versus placebo, mirtazapine have some efficacy. Now, this is a study that was conducted by Grant Colfax at UCSF, and it's a larger sample. It's still a very modest size, sample size. It's only 56 subjects. It's comparing mirtazapine 30 milligrams QD versus placebo. And as you can see here, there is a trend towards a reduction in methamphetamine use compared to placebo. Based on this data, NIDA supported the development of a larger study at the same site at UCSF. It was conducted by Phil Coffin, and the results of that study were presented to NIDA recently. They seem to be quite promising. They brought the data to the FDA, and the FDA was enthusiastic about the data. Now the FDA required that they have to have a drug-drug interaction because there are no interaction studies looking at methamphetamine and mirtazapine. So the FDA is requiring to have that type of drug-drug interaction study before we can move forward with a phase 2, larger phase 2 or a phase 3 clinical trial. But this is one that seems promising, and we are, again, NIDA is going to continue supporting this medication, and the next study will be the drug-drug interaction study. Now, the other compound that in this case is a monoclonal antibody. This is a very fascinating study, and it is in a phase 2A phase in terms of the clinical development. It is being conducted by a group at the University of Arkansas, Mike Owens and his group, and they have demonstrated in a phase 1 study that a monoclonal antibody that they develop that has an effect for 1 week can block the access of methamphetamine to the brain in concentrations and have low concentrations in the brain enough to prevent not only overdoses and prevent from the neurotoxic effects from methamphetamine, but eventually it could help people to stop methamphetamine use. So now NIDA is supporting the development of a phase 2 based on the phase 1 data that is quite promising. And also, as I mentioned before, the effect of the monoclonal antibody is for 1 week. But we know that for patients with methamphetamine use disorders, even a once-a-week treatment is very difficult to retain in treatment. So based on this data and the efficacy of this monoclonal antibody, we are in the process of supporting the development of a longer-acting monoclonal antibody that will have an effect of hopefully of 1 month. That way, patients will come to the clinic and will get their monoclonal injected once a month, and they only have to make a good decision once a month. So that seems to be quite promising, and again, we are very excited with this development, and this is one of the compounds that we think has good promise. The other area that I'm going to touch very quickly is cannabis. Cannabis also is a program that is being supported by NIDA. And this is the data from the past year marijuana use in the United States. This is not a surprise, given the wide increase in the legalization or decriminalization of cannabis in the United States, and the increase in use and for many, many purposes, and not only therapeutic but non-therapeutic purposes. And this is the number of people that have received treatment for cannabis use disorders in 2017 to 2017, again, decreasing the number of people. And in this case, we know that part of this, the reduction in the number of people that are seeking treatment for cannabis use is because of the changes in the perception of risk. We know that in the general population, there is a perception that cannabis is not a risky drug. But we know that it is, and we think that there are people that are suffering from cannabis use disorder, and we know that there are people that are seeking treatment, and for those, we are still moving forward with the medications development for cannabis use disorders. Now, we don't have any medication approved. We have tested many, and the only one that we have at an advanced phase is a Fa inhibitor. In the previous presentation, we heard about Fa is the enzyme that breaks down anandamide. Anandamide is the endogenous cannabinoid, and this is a Fa inhibitor. You probably have heard about Fa inhibitors here in France because of there was a bad effect of a Fa inhibitor. This Fa inhibitor apparently has a different mechanism of action. It's not risky. It was tested in a phase 2 trial at Yale University. This is the data. This is the study. It was a phase 2 study that was conducted and with all the rigor, and the results seemed to be quite promising. There were 218 people that were screened, and that was the consort And this is those are some of the results that I plotted from the paper that was published by De Souza. This paper and that study was a cooperative agreement. A cooperative agreement means that was a close collaboration of Yale University and NIDA. We were very intimately involved in this study. And as you can see here, this is the number of joints per day. At treatment week 4, there was a significant reduction between placebo and the FA inhibitor. And this is the urine toxicology results, the quantitative. And you can see here there was a significant reduction. And it was very interesting that the marijuana withdrawal symptom checklist, it was a significant difference in between placebo and the compound. So this is one that is NIDA also is now supporting a phase 2B clinical trial. Unfortunately, we thought we could move forward with a phase 3 trial, but the FDA said, no, you have to do another phase 2. In this case, will be a phase 2B to replicate those results. So we are now in the process of replicating those results. Again, as I said before, no medications are approved by the FDA for any of those 3 substance use disorders, cocaine, methamphetamine, or cannabis use disorders. We are right now very active on opioids, but now we know that we're going to have to be extremely active on those substance use disorders. And this is a paper that was published by our group in December with some of the new targets at the preclinical level that we are in the process of developing and testing. So I mentioned the Erection 1 and I mentioned the 5-HT2A, and this is a long list of other compounds. And we recently, last week, we had a meeting with experts at NIDA trying to elicit and get from them feedback to see what other compounds will be of interest to test for those substance use disorders, and we are open to any suggestions. And right now, we have funding opportunities at NIDA to support research. In fact, we have funded studies here in France supporting research for treatment of those disorders, and we are hoping that we are getting more, we'll get more medications. And our main goal is, and I hope that before I retire from NIDA, is that we will see at least one medication approved for any of those disorders by the FDA. With that, I want to just summarize. This is the pipeline. Those are the most promising for cocaine. I would say lorcaserin with a question mark, and then now with the orexin 1 antagonist for methamphetamine, mirtazapine, and the monoclonal antibody, and for cannabis will be the FA inhibitor. And with that, I want to thank you for your attention.
Merci, Ivan. Thank you, Ivan. Again, all the questions will be at the end because of time issues. I want to apologize to our international speakers for the technical glitches we've had up to now, but it's currently being resolved. They need to reboot all the computers. And while they do that, I will invite the next speaker. Donc, je m'excusais auprès des présentateurs pour les petits incidents techniques. Le système est en train d'être redémarré. Et sans plus attendre, j'appelle le prochain orateur, le professeur Wim van den Brink. Wim van den Brink est un des plus grands chercheurs en Europe dans le champ des addictions. Il travaille avec une équipe extrêmement riche à Amsterdam. Ils ont publié énormément de papiers dans différents domaines. Ils sont connus notamment pour cet essai thérapeutique sur l'héroïne, hein, qui était un de ceux de meilleure qualité, qui a été publié dans un journal de très haut impact. Et aujourd'hui, Wim va nous parler des enjeux de la médecine de précision, de la médecine personnalisée dans le champ des addictions. And it should be
Thank you very much.
okay.
Marc, you helped me the first slides probably. Ah,
Yeah,
that's
this
nice.
is right. So it should, and
Yeah.
this is going that way,
Yeah.
and this is that way.
Very nice. So I'm very happy to be here again. I think, like Ivan, I've been here many times, and I'm enjoying it massively to be here. And I don't know a place with higher hospitability. It's just a great place to be and wonderful people. So in the coming 25 minutes, I'm going to talk about a huge issue. It's an issue not only in addiction, but I think we're making progress in addiction. It's precision management, or maybe personalized treatment. And so I have to say that I'm a sinner. I do it with many companies. Some people call me polymorph perverse, but I would say it's different. It's unlike in some other fields in psychiatry. I think pharmaceutical industries are still interested in treatment of addiction, and so there's new compounds coming up all the time. There's a lot of repurposing, and so it's a great time to be there. So in the coming 20 minutes, 25 minutes, I'm saying a few words about addiction as a brain disease, because that is the start of thinking about medications as a potential solution for addictive disorders, and say a few words about the neurobiological and psychological treatments, and especially talking about improving efficacy, because we have a lot of efficacious medications, but it seems that the effect sizes are not very big. And so maybe we could do something about that. So this is, I think, the seminal paper, and it's already like, it's more than 20 years ago that the then director of NIDA, Alan Lesher, wrote in Science the famous paper, Addiction is a Brain Disease and It Matters. And it matters for many reasons, for social reasons, but also for reasons of potential treatment, and that is that if it's a brain disease and it involves difference and abnormalities in neurotransmitter levels, then maybe we can also do something with medications to treat these brain diseases. Why does he say that? Because addiction is very strongly genetically determined. 40 to 60% of the variability is defined by genetic components. And this is a model that we borrowed from Gottesman and Gould when they wrote a paper on the endophenotype in schizophrenia. And this is how we translated to the model for addiction. And so what you see here is the genetic vulnerability that people may have. You see the lines, and they are the chromosomes, and on the chromosomes there are genes, and certain combination of genes define the kind of brain that you're born with. And the brain has different functions, and that might be called the endophenotype. You can't observe it directly, so you have to work hard to see these characteristics. And some of these endophenotypes include a tendency to get easily conditioned to positive stimuli, but also things like here, like what is called conflict monitoring inhibition. You could also say impulsivity. And if you have a tendency to develop these kind of impulsive behaviors, the probability becomes bigger that you become addicted. It doesn't mean that if you're born with these genes and with this kind of a vulnerable brain that you automatically develop the phenotype of an addiction, because there's also social and psychological influences. And these people were geneticists, and they have problems with the word environment, so they call this epigenetic influence. But it's environment, you know. And of course, then if you start using drugs, the brain is changing because of the drug use. And so this is how we can think about addiction. And I'm going quick. Oh, maybe there's one in between. Yeah. So what is this kind of brain that addicts have? And just very briefly, actually what it is, and that is Nora Volkov's ERISA model, which is the impaired response inhibition and salience attribution. People with addictions are actually characterized by hyperactive motivational system and a deficient cognitive control system. To make it a little simpler, this is the way we can think about it, that if certain people use certain drugs, they repeated feel reward, and they develop, or the brain develops, something you can call attentional bias. Whenever there is some things in the surroundings that reminds them of the pleasant feelings of drug use, they get this attentional, they get motivated, they develop in the brain. You see activities mainly in the ventral striatum, but also in the orbitofrontal cortex, and you could call that cue reactivity. That's the reaction of the brain to these stimuli. And that is not in all patients, but in many people, they become aware of that change in the brain, that activation of the brain, subjectively, and they experience craving. Now, that's a nice thing, craving, because it gives you a warning signal. Get out of this situation on two conditions. The condition that your cognitive control system is working well, so that if you get in this situation, you feel craving, you feel a kind of a conflict, like want to have the reward immediately, but at the same time being afraid of the long-term negative consequences. Now, it seems that some addicts, they don't have such a good conflict registration system, mainly in the anterior cingulate cortex, and so they immediately go for the immediate reward. Now, that's not so bad as soon as you have a good motor control system, and that is another thing that is impossible. Motor inhibition is not so well. So although you get this nice warning, people easily move into drug use and relapse. I use this model, okay, one more slide. Recently, this was the model, but the last few years, there's much more talking not only about the positive reward of drugs and the attentional bias and the craving and the relapse, but also the negative reward. People start with using drugs or alcohol because they feel this positive reward, impulsively use it. But with time, actually the reward goes down and the negative consequences go up, and you see that they mainly start to use drugs for relief purposes, and the impulsive use becomes a kind of compulsive use. And there are different neurotransmitters involved. For example, here most of the time it's the mu-opioid receptor that is important, but in the chronic state it's much more the kappa-opioid receptors. And this is probably then the better model, that it's not only the drug-related stimuli, but also the internal stimuli like stress and withdrawal that might cause cue reactivity and craving. Now, I use this model because actually this is the way we can also model our treatments. Like, how can you treat addiction? You can try to actually stop the reward. And if you can do that long enough, maybe also you reverse this whole thing of attentional bias and you interrupt this negative cycle. Another way to do is that you might reduce the stress. If you reduce the stress, then this stress mechanism that causes cue reactivity gets reduced, and maybe you interrupt that process also. A third way is to make sure that you have anti-craving medication, and that reduces craving. This is, of course, also a very nice one, because these were always, all these activities were involved in the hyperactive motivational system. But you might also actually enhance the deficient cognitive control system by, for example, cognitive enhancers. I'm sure everybody thinks about methylphenidate at this moment, but we have some other ones also. And then finally, if that doesn't work, you might say, okay, I can't prevent relapse, and so they're using the drug, but maybe we can do substitution treatment with agonists that are at least safe, longer acting, or not injected. For example, methadone in the treatment of heroin addiction. So what do we have, for example, for nicotine in that kind of a model? You can say we have an antagonist, maybe N-acetylcysteine, maybe it's one. It's not on the list anymore by Ivan. It was promising in adolescents, and then there was a negative study in adults, and I'm not sure it's completely off the table, but it was actually a nice, interesting model. Anti-craving medications, there have been studies here with nicotine, varenicline, bupropion, and nortriptyline. I have them in bold because these are registered medications for this indication. But again, maybe N-acetylcysteine might be involved there. Here, maybe cognitive enhancer, maybe nicotine replacement is also a cognitive enhancer in varenicline. And finally, varenicline and nicotine enhancers are probably also agonists. So they actually play different roles in the system. E-cigarettes I don't want to mention anymore because there's so many problems around. I'm not sure that it's the e-cigarette itself or the perversions of it, but let's see what goes on with e-cigarettes. So similarly with alcohol, I think there we have a very rich palette now, Antagonists, we have naltrexone and nalmefene. I also mentioned here disulfiram. It's not a real antagonist, but it even has aversive action, and it really makes sure that this repeated reward and attentional bias probably is reduced. There's an anti-stress medications. I think the most interesting one by now is doxazosin, which is an alpha antidiuretic antagonist, which seems to work very nicely. Anti-craving medications. Acamprosate is the longest that we know, and you see it's in bold, and so it means it's registered for the indication. But I think one of the most effective medications, I think, in alcohol dependence is topiramate. It has its problems, and it's not registered for that indication, but I think it has the best papers by now to be one of the most promising medications for alcohol dependence. Maybe low doses of baclofen might be the anti-craving drug. Phenytoin, especially in smokers that also have an alcohol dependence, have very good data to support it. A cognitive enhancer, I think there's modafinil is on the list there. Again, it's not registered for that indication, but I think there's interesting data that could support that. And then agonists, it's an interesting thing. For long, we're looking for agonists in the treatment of alcohol dependence. Of course, baclofen, high-dose baclofen might read there. Maybe gabapentin, although it's not a GABA agonist, but it seems to have some agonist characteristic, and sodium oxybate. These might be agonistic treatments. And of course, kinds of alcohol that are being used as in treatment of homeless people in Canada and some other countries. So I think you have a rich palette of drugs that can be used. So in terms of what we have available, it's quite nice with alcohol dependence, isn't it? We have different treatment goals, abstinent or reduced drinking. We have the first choice options, I would say, because they're registered for the indication. And of course, you go first for the registered indication before you go to any off-label medication. I have disulfiram as a second choice treatment. I think I know that people say it's first-line treatment. I have it second line because there's so many contraindications and there is so many side effects. So let's see what will be the development there. And you see, there is the other third choice treatments. We'll see what goes there. It's off-label. And so I think there is a call here for not only for scientists, but also for professional organizations to think about when they write their guidelines to say something about these new medications. Because if you want to prescribe off-label, you need some support from your professional organization or maybe also from the political organizations. This is opiates, so it's the same. I'm not going to talk a lot about opiates, but you see, you can say the same kind of medication you can mention. Cocaine use disorders, there were a lot of them that looked interesting. I think none of it is available yet. Although I missed in Ivan's lecture, I think I missed a little bit things like modafinil, bupropion, and dexamphetamine, slow-release dexamphetamine. I think there are interesting studies, and I think substitution treatment is maybe not popular in the US, but it might be one of the most promising ways to go with stimulants. And we did a study on it with very promising results. I think Francis Levin, who's going to speak later, was looking at dexamphetamine salts, very promising in comorbid patients. And finally, here's it's cannabis, and there is just very little. I agree with that. It's highly needed to do more. Now, we have so much available, but then comes this. These are registered medication, acamprosate and naltrexone. But then you see the numbers needed to treat. You need to treat 11 to 20 patients to have one responder. That doesn't make you happy, isn't it? It's an effective medication, it's registered for the indication, and the numbers needed to treat are so high. This is for nalmefene. It's a review that we did on the nalmefene that is registered in Europe, not yet in America. And you see effect sizes ranging from 0.30 to 0.40. This is what you see here, 0.27, 0.30, 2.50. And now you might say, okay, nalmefene is not so good. But if you look at the other alcohol treatments, It's 0.12 to 0.30. It's also not so good. But then antidepressants don't do so well. So some people have said, you know, addiction is not a medical field, so stay away from medications. It's nothing. It's not going to be anything with you. But that you could say also from psychiatry then. Psychiatrists need part of medicine because your medications don't work. Even your antipsychotics, it's not great. It looks a little bit better, but it's not great. But then comes this wonderful study from Stephen Leucht in 2012, and he said, let's look at psychiatric medications, let's compare them to general medicine medications, and look at the effect sizes. And you see the mean effect size of the general medicine medications was 0.45. Not great, it's a small effect size. And then in the psychiatric medication, it was 0.49. It's a little higher, it's in the same range. Not very good. But maybe medicine doesn't belong to medicine. So maybe there is something else wrong. We don't know what kind of medication to give to one patient. And see, here is alcohol dependence. And so it's really in the middle of medicine. So we're in the middle of medicine, but we're not happy with our numbers needed to treat, are we? So the question is, what can we do? Can we do better? And so I think there's a few options whether we can improve effectiveness. One is medication only work when people take the medication. So we have to improve compliance by combining it with psychotherapy, or as Ivan was showing already with the monoclonal antibodies, like having long-acting formulations. That is ways to do it. And we have some of these, and we have to go on there. Combining pharmacotherapy and psychotherapy is an interesting way. For example, pre-exposure therapy with a medication like dicycloserine. Maybe that's a way to go to improve the reductions in craving. Combine different medication. I think far too long we abstained from polypharmacy. I think there's many areas in medicine they can't do without different medication with different mechanisms of action. And I show there are different mechanisms of actions that you give them at the same time. And there is some indication that acamprosate and naltrexone together do better than either of the medications separately. Of course, we can wait for new medications. It's going to be long before they're there. There will be probably nice cannabinoids to come, but it will take quite some time. Repurposing, and that's what I showed. A lot of medication that come from other fields that we can try and see whether they can be used. And finally, I think the whole field of medicine is waiting for patient treatment matching. Find the right patient with the right medication, because that will increase the situation. And do we have anything to say about personalized medicine, treatment matching? So the first thing is to know is that you can actually match your patient and the treatment or the medication on both the phenotype, the endophenotype, or the genotype. And there's different reasons for that. And that, you see, if you do it on the genotype, it's very nice because it's high stability. You have it and it doesn't change anymore, the genotype. It's highly feasible. The costs are moderate now, but they will be very low in the future. And it's very close to the biological process. So I think these have great promise. Whereas endophenotypes, I think the stability can be higher, but most of the time it's quite low. Feasibility is problematic. The prices are high if you want to do fMRI. You don't want that as a matching variable. It's fancy, but it's not going to happen, isn't it? And although it's close to the biological process. And with the phenotype, yeah, it could be done. It's feasible. The price most of them low, but it's pretty far away from the biological process. So if you want to predict medication effects, maybe it's not the best predictor. So what do we have, especially when we think about alcohol dependence? I think this is a study by meta-analysis by Henk Krenzel. It shows that gabapentin, and there's going to be a lot of talks about gabapentin today for the we know that it only will reduce heavy drinking. It will not go into abstinence. This is more important. Many years ago, 2005, we did a study on acamprosate, and we wanted to predict whether acamprosate was better than placebo in certain patients. And although the study did better in patients with severe craving and high anxiety, they did so both for the placebo and for the acamprosate, and there was no interaction effect. So no predictor for the effect of acamprosate. This is a little bit more interesting. This is a recent study from Australia, and showing that if you have baclofen, relatively low doses, it works only in patients with a comorbid anxiety disorder, which maybe fix things you can think about it that could be reasonable, because if you think about the profile of baclofen. And a later study, I will show the data later, also showed that it only seems to work in patients with certain variation of the GABA-B type 1 receptor. So here you might have an indication of a subpopulation of alcoholics that might benefit from low-dose baclofen. This is probably one of the nicest things that I know, that is sweet liking. If you are a sweet liker, you might respond much better as an alcoholic to naltrexone. What is it, the sweet liking? We don't know exactly, but probably it's related to the family history of alcoholism, because people with a family history of alcoholism are also very high in sweet liking. This is now being replicated 3 times, and it's an interesting thing. There's also a downside. It's only 10% of the alcoholics that are these very extreme sweet likers. But in these sweet likers, naltrexone seems to work much better than in people who don't like very sweet stuff. On the endophenotype, because this was all phenotype, on the endophenotype, I think there's interesting things. This is an old study, 10 years ago, in pathological gamblers. And what they show that if you give them modafinil, which is in American terms a wakefulness promoting drug, here they call it just a stimulant, if you are low impulsive, then it seems that you become more impulsive from modafinil. But if you're highly impulsive, impulsivity goes down. And moreover, there's also a relationship with craving. So we saw that data, and then we were interested to see what modafinil does in patients with alcohol dependence. And so we did a study with modafinil 400 milligrams, and what we saw is no effect at all. But then we separated. We had pre-stratified on high and low impulsive patients. And what we saw is modafinil improves the outcome in terms of abstinence days in the ones that were high on impulsivity, and actually it was detrimental for those alcoholics that were low in impulsivity. So it's not like if it doesn't help, it also doesn't damage. No, it does damage in people who are very low impulsive alcoholics. And you might think of low impulsive alcoholics as late onset alcoholics, who are more often being low impulsive. So here it's a very interesting finding that both in pathological gamblers and in alcohol, it seems that you have to take into account the level of impulsivity if you start to give the treatment. This one I'll skip. The genotype, I think that's the most promising part, yes. This was a first study. This is poor man's genetics. It's family history. Family history positive on alcoholism. And if you see these data, then you see actually if you have more people, if you have people with a high amount of family history problems of alcoholism, naltrexone works better. It's also if you have alcoholics that are less social, more antisocial, naltrexone works better. We thought that would be more or less the same, that the antisocial would also be the family history alcoholics. It wasn't true. It was independent risk factors. This is the nice data from on the doxazosin that I mentioned before. Here you see again that doxazosin reduces alcohol craving and alcohol use in heavy drinking days, but only in patients with a family history of alcohol dependence. Actually, it might actually be negative in patients without a family history. Here's the same thing, giving naltrexone or nalmefene in pathological gamblers. It doesn't work that well, so people were looking for predictors, and the only one predictor was a family history of alcoholism. This is, of course, the most important thing that we ever know. naltrexone and the mu-opioid receptor gene variation. And it's been studied now many times, and there's positive and negative results. This was the first study showing that if you have the right mu-opioid receptor gene, then the effect size between the naltrexone and placebo, you see, is numbers needed to treat becomes 3 or 4, whereas in the unfavorable variation of the mu-opioid receptor gene, the numbers needed to treat is 7 to 8. Now, the problem is these people are only 32% of the population in white American population. The interesting, this is a meta-analysis that was done in 2012. This is another meta-analysis showing actually that there is, if you have the right variation of the mu-opioid receptor gene, you're more likely to respond to naltrexone. We also probably know why that is, because people with the AA variation of the mu-opioid receptor gene have lower response to alcohol than the ones with the AG, and it's the AG that is actually responding to the naltrexone. So we also have a mechanistic explanation for that precision medicine. Now, this is the disappointing thing. Then there was a randomized control that was pre-stratified for the mu-opioid receptor gene, and it didn't show an effect of the patient precision and matching effect. Now, I must say this is an important study, and we shouldn't deny it, but we also have to say that there was no effect at all in the whole study of naltrexone. So maybe this is not a negative study, but also a failed study, because there are many studies that did show an effect of the mu-opioid receptor gene. This is probably one of the more interesting ones. It's the effectiveness of topiramate in the treatment of alcohol dependence. I already said maybe one of the most effective medications that we have now, with its problems, with side effects that are problematic. What you see here is the study from Hank Kranzler. And what you can see very easily, I think, you can show it all, that this is the medication is better than the placebo. But you can also see that in the subgroups with these variations, the AA and AC genetic variation of the GRIG1 gene, there's no effect at all of topiramate, whereas in this specific genetic subtype, the effect size are massive. Numbers needed to treat like 3 or 4. So here we have a wonderful effect in 42% of that population. And it's actually creating the whole effect. And a next study they did, they looked okay, but topiramate also has negative side effects. So let's make a balance between the wonderful effect in the GRIG1 gene, but also the side effects that you have. And you have to read it. It's a nice study. It shows that despite the fact that there are negative side effects, it's the overall risk-benefit of this medication is very, very, very good. This is, I mentioned already, again, the study from Kirsten Morley from Australia, showing that low doses of baclofen only seem to work in patients with certain variation. The CC genetic subtype of the GABA B receptor 1 subtype, very nice. This is a very interesting studies of the German group showing that camprosate is working more effectively in patients with a certain variation of the GATA4 gene. And so we can start to think about who's going to be treated with what. And first we ask, or we decide together with the patient whether he wants to go for abstinence or reduced drinking. Now, maybe most of you want to go for total abstinence, but a lot of patients don't want that. And there's good indication that reduced drinking can also be an option. And here you can see that we might have some indication of which medication to give to which patient. And so if you think about naltrexone, you can think about patients with antisocial behavior, patients with family history positive, patients with very strong sweet liking. And of course, if you want to do it, and we do it in our clinical setting, we just we assess the mu-opioid receptor gene. It's very cheap if you have it installed in your clinical practice. It costs some time and some money to organize, but if you have it, it's less than 20 euros. So we do it now. We also give topiramate. We look at the GRIG1 gene, and so we treat basically, or our initial treatment is based on this patient-treatment interaction in precision medicine, and we think we can do a lot. And so you can go on and see here different options that you might have for patient treatment matching. In nicotine dependence, there is much less. Although we have a variety of medication, we could think about patient treatment matching and personalized medicine. There is a little bit, and that has to do with the metabolism of nicotine, and it's influenced by the Cb2 and so you have slow and fast metabolizers, and what you can see in this picture that if you have normal or fast metabolizers, you can better probably provide varenicline, and only in the fast metabolizers you can think about nicotine replacement therapy. The genotypes, there's not so much done in nicotine treatment, but there are indications, and it's only indications so far, that if you have certain variations of the serotonin transporter gene, you might have better effects of medications, both of bupropion or non-triptyline. You see here you have 50% success rates in people with the active medication. This is a summary of it. It's much less known in the treatment of nicotine dependence. There are developments and interesting, and then I'm going to finish quite quickly. This is an old study, but probably one of the most interesting ones, just looking at GWAS data and predicting which patients with nicotine dependence might benefit most from either nicotine replacement or bupropion. And so they found combinations of specific SNPs for the different medications, and I think that's a way forward. So my conclusions are actually that a lot is going on, but it depends a little bit where you look at it. I look at it as like very promising. Not hard evidence yet, but definitely as far as to become happy from it and to start practicing this kind of personalized medicine. If you're somebody who's probably an even more serious scientist than I am, then you say currently the evidence regarding genetic predictors of medication efficacy is very limited. I would say it's very promising, but not conclusive. But somebody else says it's limited. Thus, the precision management is not yet ready for widespread clinical implementation. I would say not widespread, but for clinicians that are well aware of the possibilities and have good relationship with their patients, with good explanation how to use off-label medications, and using these strategies of finding the right patient by the right medication. I think there are possibilities. So addiction is also a treatable brain disease. We have new pharmacological treatments available, unfortunately with limited effect sizes. We have to think about polypharmacy, but I think the most interesting development is personalized or precision medicine, especially in alcohol and nicotine. We can use them in finding the right medication for the right patients. And of course, larger studies with well-designed treatment are needed to prove all this. But I think it's a hopeful message, and I think it's time to implement it in clinical practice. Thank you very much.
Merci beaucoup, Wim. Thank you. On va donc, comme on l'a dit, sans transition, accueillir Margaret HANEY. Alors, les gens connaissent Margaret HANEY puisqu'elle a l'amitié de venir nous voir en France. Elle est venue plusieurs fois à Paris et je pense que c'est la deuxième ou troisième fois qu'elle vient à Biarritz. Non? The first? C'est la première fois. Parfait. Bon, bah, il était temps, mon cher Jean-Pierre. Rapidement, Marc. Absolument. Elle connaît la région puisque c'est ce que j'allais dire. Elle a vécu à Bordeaux et puis elle a été l'élève de nos maîtres, si je puis me permettre. Alors, Margaret HANEY est une grande chercheuse à l'Université Columbia, évidemment qui connaît des personnalités de recherche de grand niveau, de talent. Alors, pour ma part, j'ai eu l'occasion d'aller la voir parce que comme j'avais, à l'époque, je fais rapidement, quand j'avais fait ma thèse sur le cannabis, elle m'avait invité à venir visiter son laboratoire. Et ce laboratoire, moi, je l'ai toujours gardé en tête, c'est un petit studio dans lequel elle avait des jeunes qui vivaient, qui fumaient. Voilà, c'était ça son laboratoire, entre autres. Et j'étais effaré. Et ensuite, elle recueillait les données, elle discutait avec eux. Et ça donne une des plus grandes chercheuses sur le cannabis que nous connaissons. Merci beaucoup de nous faire cet honneur, Margaret.
Merci beaucoup. Je parle anglais. I'm going to speak briefly. I think we're running out of time here. Let me just go back one, sorry. So the title of my talk is Cannabis Yin and Yang, and I like to speak about cannabis in terms of both of its abuse potential, but also its therapeutic potential. But I'll be doing the talk this afternoon on the therapeutic potential, so I'll be focusing mostly on its abuse-related effects. I have no conflicts of interest. So the outline of my talk, I'm first going to describe, and thankfully, being the last speaker, much has been covered already. But I'd like to give some definitions, some public policy, and some regulatory barriers we're facing. And then I'll focus mostly on cannabis use disorders. So I just need to insert this slide about the yin and yang of cannabis. Is cannabis good or bad? It's both. It's a pharmacologically complex plant with the constituents that have the potential for producing both medical benefit and abuse liability. In the United States, anyway, our societal discussion and our public policy lacks any nuance. Cannabis is extremely polarizing. It's viewed by some as a miracle cure and by others a hazard, and there are really two extremes. And just one example of this is neuropsychopharmacology asked me and another colleague to discuss, to evaluate the evidence for two psychiatric disorders, PTSD and psychotic disorders. And we wrote a paper, Does Cannabis Cause, Exacerbate, or Ameliorate Psychiatric Disorders? An oversimplified debate discussed. And this fellow scientist and I evaluated the same evidence and came to different conclusions. So even among scientists looking at data, cannabis can be polarizing. So again, I'm going to go very briefly through this because this has been nicely discussed, but there, in terms of definitions and what I'll be discussing, there are phytocannabinoids. This is a hemp plant with over 100 phytocannabinoids. Delta-9 THC, when we think of cannabis intoxication, we're really thinking about the effects of Delta-9 THC. And when we think about potency of the plant, we're always talking in terms of Delta-9 THC. And as we saw earlier, in this session, potency has been rising dramatically. You can get more money for the more potent your cannabis is, so of course that's been increasing. And there are really new ways of getting cannabis into your system that have tremendous impact now. It's distilled into a waxy formation, or THC is put in oil, and this is 80 to 90% THC. So this is potency humans haven't really seen before. So this opens up all new implications in terms of cannabis use disorder. So as we learned, cannabidiol is not terribly intoxicating. It's typically in very low concentrations in recreational cannabis. So in terms of, in the United States, there are 3 FDA-approved cannabinoids. 2 are synthetic oral capsules. Dronabinol is Delta-9 THC in synthetic form, and Nabilone is Delta-9 THC analog. I'll be talking a bit more about Nabilone. I happen to prefer it to Dronabinol. I think it's a better medication. But these are FDA approved since the 1980s for anorexia, nausea, and vomiting associated with HIV and chemotherapy. And more recently, we've had this cannabis plant extract, which is CBD from the plant. This is Epidiolex, and it's used for severe childhood epilepsy. And as we heard, again, we also have the endocannabinoids. So cannabis is an old drug, but a new science, and certainly Raphael Mechoulam is the pioneer of all of this in Israel. But it wasn't really until the 1990s that our first, the cannabinoid receptor was cloned, and again, it is everywhere in the brain. It's I think, the most common G-protein coupled receptor in the brain. It's in everywhere associated with psychiatry. And understanding its role in neurobiology is still somewhat in the frontier. We've learned a lot, but there's still so much to learn. 1992, the anandamide. 1993, the second cannabinoid receptor, the Cb2 receptor, not present in brain, I think, unless in cases of pathology because it's associated with the immune system. In 1994, I entered the field more because once cannabinoid antagonists were developed, and one could demonstrate in animals administered THC that you could precipitate withdrawal by administering a cannabinoid antagonist. That opened up, my research world completely. In 1995, the second cannabinoid agonist was discovered. So in terms of cannabis use disorder, currently in the United States, 21% of citizens live in states where recreational cannabis is legal. We've undergone this tremendous societal shift in attitudes towards cannabis. And as mentioned, with legalization, there's increased public acceptance and a steadily increasing potency. And so daily cannabis use among adults is increasing, and so is the rate of cannabis use disorder. And, unfortunately, pregnant women are using more cannabis. It's, again, the societal acceptance is so high, people are turning to cannabis for nausea, and it's really promoted as a wellness medication. And it's a bit tragic considering the brain development going on at this time in fetal development. In the United States, about 30% who smoked cannabis in the past year met current DSM criteria for cannabis use disorder, and it's estimated about 4.2 million have cannabis use disorder. And a subset of these individuals seek treatment. As Yvonne mentioned, it's fewer than should are seeking treatment, but there are a subset, and they're seeking treatment. These are not just mandated for treatment. These are individuals seeking treatment for their own initiative, and their reasons for seeking treatment are a bit subtle compared to alcohol or cocaine or opioids. They're dissatisfied with their functioning, they're smoking more than they intend to, they have memory effects, they undergo withdrawal, they have health concerns, they neglect responsibilities, and what's surprising to many is it's very difficult to stop. Once you're smoking every day, frequently throughout the day, quitting is a problem, and relapse rates are actually as high as they are for other drugs of abuse. So qualitatively, cannabis use disorder is similar to other substance use disorders in terms of withdrawal. It's disruptive, and it's persistent. It's difficult to quit. And there's no efficacious treatment, as we've heard several times. Few patients achieve long-term abstinence, even with evidence-based behavioral treatments. And all of the randomized placebo-controlled pharmacological trials, there haven't been many, but they've all been consistently negative. So we think that a variety of treatment options are needed, and pharmacotherapy is one of them. And so that's been the focus of a lot of our work over the past years. So as Amine mentioned, we have this unusual but very rich source of data at Columbia. It's a human laboratory model of cannabis use disorder. And we view this as a translational bridge between preclinical studies and clinical studies. So in a small number of people, in a very intensive series of studies, we can collect a lot of data. So we bring heavy cannabis smokers, not treatment seeking. They smoke daily throughout the day. They wake and bake. They start first thing in the morning and go all day. And they come into the lab. We have them smoke cannabis in a controlled manner, and we're measuring their behavior around the clock. So mood and drug effects. We look at sleep. As mentioned, sleep is incredibly important. Food intake is an important effect of cannabis, drug craving, cognitive task performance, and cannabis self-administration, which our working hypothesis is when you're looking for a medication with a signal that's going to work clinically, this is the behavior you want to target. You really want to look to see if your medication can actually reduce drug taking in this laboratory setting. So again, as my previous speaker mentioned, there's different targets one can take with a medication. You can focus on relapse prevention, and so the idea is in an abstinence drug user, can you target, say, cannabis withdrawal symptoms and reduce the likelihood that they'll return to cannabis use, or focus on abstinence initiation. So these are non-abstinence users. Can you decrease the direct positive subjective effects? I feel a good drug effect after smoking, and reduce cannabis self-administration among people who are currently using. So I'll first describe our work on relapse prevention. It's been the bulk of our studies. So to do so, I just want to describe, for those of you who aren't aware, what cannabis withdrawal is like. And because of this rich laboratory environment, we could be one of the first that really demonstrated a time-dependent withdrawal phenomenon from cannabis. So it's characterized by increased anxiety, irritability, depressed mood, restlessness, marked decreases in food intake, and sleep quality. So as mentioned, almost all drugs of abuse during withdrawal disrupt sleep, and cannabis does so very robustly. Because THC has a long half-life, it takes usually 24 hours or so for the withdrawal symptoms to kick in. It's unlike cigarettes with after several hours, people start to get uncomfortable. With cannabis, it takes longer. It peaks really between days 2 to 6 and lasts about 1 to 2 weeks. And it contributes to the maintenance of daily cannabis use. So we learned early on in testing a range of medication that just decreasing withdrawal is not sufficient. One of the medications discussed previously was mirtazapine, and we tested mirtazapine for cannabis, and we saw really robust effects on improving sleep during withdrawal and certainly returned food intake to normal. Didn't shift drug taking, and so again, so we think that is an important signal. Many medications, we can shift the withdrawal symptoms, but unless we shift drug taking, we think we don't have a good signal. So we have a model of relapse. So participants are in the laboratory, they undergo several days of abstinence, and then they have the option to return and self-administer cannabis in the laboratory, but they have to pay for it. They have to spend money to return to cannabis self-administration. So some do and some don't, and we like to see if our medication can shift them from relapsing to not relapsing. And so these are not all of our studies, but there's a lot of our studies. These are the medications tested in human laboratory studies that have had discouraging effects and encouraging effects. A lot of discouraging effects, but there is some promise. And in our laboratory, the medication that was not on Yvonne's list, but it was one we're very excited about, even though it's been a bit since we've published this, is Nabilone, which is, again, this synthetic analog of THC. And I just want to show you some of this data. This is, again, off-label. So just to orient you to these slides, these are ratings of I feel irritable, I feel high. And the first column are the days in which I have participants smoke in a controlled way at set times during the day, cannabis. And then they undergo withdrawal, so they're just getting placebo cannabis and placebo medication. But then there's conditions where they're living in the lab and they're getting active doses of Nabilone. We tested 2 different doses. So what you see is when people undergo withdrawal from cannabis, their ratings of irritability go up, and Nabilone just returned this back to baseline levels. And importantly, these were at doses and conditions where participants didn't get high. So although Nabilone certainly can produce some intoxication, it's a very slow onset, very long duration of action, and it's typically not a medication that has high abuse liability. So sleep, again, is something I mentioned. So when you see during withdrawal that participants don't sleep as well, they sleep fewer hours, they wake up more often, and their efficiency, when we have a objective measure of sleep, goes down. And Nabilone just, again, returned them back to baseline levels. Food intake, I just like to demonstrate the dramatic decrease in food intake. So under baseline conditions, when they're smoking cannabis, they're consuming over 3,500 calories a day. And during withdrawal, several days of withdrawal, it goes down by 1,000 calories a day. So they have trouble eating, and Nabilone just restored that behavior. But most importantly, it decreased our model of relapse, the likelihood that participants, or how much cannabis they self-administered in the laboratory when they had to pay for it. So currently, out of all the medications we tested, this is a medication that both decreased withdrawal, decreased our model of relapse, and had little indication of abuse liability. So, and you only have to give it once a day, which is always a plus in a clinical trial. So this is something we're hoping can get tested in a real clinical trial of phase 2 or 3. So I'm going to move now to our model of abstinence initiation, where you decrease the direct positive subjective effects of cannabis. And we've tested 3 medications for this I'd like to describe: cannabidiol, naltrexone, and a pregnenolone analog. So again, if you're trying to decrease the acute reinforcing effects of a drug, of course, you would think first of just an antagonist. And rimonabant was the antagonist that was available for a brief period of time. And Marilyn Hustis did demonstrate that with rimonabant does decrease some of the effects of cannabis acutely, but of course rimonabant has been removed. It's no longer available for research or for any use because of its psychiatric adverse events. So you could think blocking that Cb1 receptor, blocking all endogenous cannabinoid activity, seems to have consequences in terms of psychiatric consequences. So our rationale for cannabidiol, again, it's a very different mechanism of action, does not bind to the Cb1 or Cb2 receptors with any affinity, is a 5-HT1 agonist, has many other potential mechanisms of action. And there was some evidence that, and the studies weren't fantastic, there were 1 dose of oral CBD compared to 1 dose of dronabinol or synthetic THC, and there was some indication that intoxication was reduced. So NIDA funded a multi-site study to look at the effects of a range of oral CBD doses in combination with smoked cannabis, because that hadn't been done before. And the idea was if oral CBD attenuates cannabis' positive subjective effects, it may have potential as a treatment medication. So we did a study with 3 active doses of cannabidiol and placebo and looked at the subjective, cognitive, and physiological and reinforcing effects of placebo cannabis and active cannabis. So this is just a figure showing, so this is inactive marijuana, and these are the different doses of cannabidiol. We gave cannabidiol prior to having participants smoke a controlled amount of cannabis because we wanted cannabidiol to give it time to get absorbed first. And these are ratings of I feel high. So you see there is always a nice placebo effect to smoking placebo cannabis. This is cannabis where the THC has been extracted. And so we always see when people smoke that you get this placebo effect, and cannabidiol did not do anything to that. With active marijuana, they do get higher ratings of high, but cannabidiol also did not shift that at all. And cannabidiol did nothing else really to any of our other measures. It didn't shift cannabis craving or how much they liked it or cannabis self-administration. The other thing you see very reliably when you give people controlled amounts of cannabis is this increase in heart rate, and cannabidiol did not do anything there. So although we did see the prototypical effects of cannabis, CBD did not have any effect. And really, it's still lore in the field that CBD attenuates the high from cannabis, but I'm not convinced by any of the evidence, and we certainly did not see that here. So the next medication is naltrexone. We've heard a bit about that, and the rationale for naltrexone was, again, the cannabinoid and opioid systems are really overlapping in many ways. Neuroanatomically, their signal transduction, they have similar pharmacological effects in some sense. And importantly, opioid antagonists decrease cannabinoid self-administration in laboratory animals. So for this study, we randomized cannabis smokers to receive either 50 milligrams of naltrexone or placebo for 16 consecutive days. And over these 16 days, we were probing them every week or so to look at the effects of cannabis, to see if we could see any shift and when it would occur. And so this is, again, inactive cannabis. And what you see is self-administration, the percent of participants who self-administer at baseline and over the weeks of medication administration. And placebo is the open bars, and naltrexone is the dark bars. So there's a decrease. In the beginning, people will self-administer, but over time, it went down in both groups. But with active cannabis, we saw a different effect. So this is, again, placebo medication. So 40% of participants continued to self-administer in the laboratory, where with naltrexone over time, there was this significant decrease in cannabis self-administration. This is ratings of I feel a good drug effect when we gave them a controlled amount of cannabis, and again, this is inactive cannabis. And what we saw with active cannabis is that over time, how good the effect was from when they smoked a controlled amount reduced. So clearly, maintenance on naltrexone decreased the reinforcing and positive subjective effects of active cannabis compared to placebo. The question is, will patients in treatment reduce their cannabis use in response to an attenuated cannabis effect? This is the mechanism by which naltrexone reduces alcohol use clinically, and it's not a knockout effect like you see with opioids, but there is an attenuation in the positive effects of the drug of abuse. So again, of all the medications we've tested, it's rare that we can see a shift in self-administration, so I think naltrexone is something that warrants further testing with with cannabis. And again, it's maintenance on it. It's not its acute effects. Finally, I just want to describe this Pregnenolone Analog. This is a French drug, so I paired up with my colleagues in Bordeaux from 25 years earlier, looking at the effects of a medication, AEF0117. So as I mentioned, rimonabant is an orthosteric antagonist. It blocks all receptor activity and produces serious psychiatric effects. Pregnenolone binds to a specific intracellular site on the Cb1 receptor, distinct to where THC and other Cb1 agonists bind. And it acts as a signaling-specific inhibitor of the Cb1 receptor. So I just want to show you what this looks like. So this is the Cb1 receptor, and this is where THC is binding and producing a range of intracellular effects after it binds, G-protein coupled. And so this is where pregnenolone binds. And so this is the work from the Piazza lab, and they found that rodents given very high doses of THC, pregnenolone gets released, it binds to this intracellular pocket and actually decreases many of the effects of THC. And it doesn't shift any of THC binding, so some allosteric modulators will actually shift how the agonist binds, but it doesn't. THC binds the same way and produces some of its intracellular effects, but not all of them. So phospho-ERK is blocked, and with that, just one of those intracellular effects being blocked, the abuse-related effects of cannabis in animals was blocked. And so again, you see how rimonabant would just block everything, but pregnenolone is just blocking certain things that THC does. So pregnenolone is a poor medication in and of itself. It has a short half-life, it metabolizes to other steroids, and it has low bioavailability. So, so they developed a pharmaceutical company, ALIS Pharma, that developed a new medication, AEF0117, and it turns out to have a very large safety window. It attenuates the THC's effects in preclinical models without any of the problems of the orthosteric antagonists like rimonabant. It does not precipitate withdrawal. It doesn't decrease food intake under baseline conditions. It doesn't increase animal measures of anxiety. And most importantly, it attenuated self-administration of cannabinoid agonist in rats and monkeys. So, so with NIDA's help, we have this strategic alliance, and we were able to move this medication from rodents into humans. And we first conducted phase 1 safety studies, single-dose administration studies, multi-dose administration studies in healthy volunteers, testing 4 different doses of AEF0117. And then we started in our laboratory. It was kind of the ideal setting to be able to combine the effects of AEF and cannabis in daily cannabis smokers. And so we bring people in on 2 occasions for 5 days each. And 1 occasion they're on placebo, and 1 occasion they're on an active dose of AEF. And we have them smoke cannabis at set intervals during the day. And we're really we're able to measure all of the things we're interested in, the abuse-related effects, cannabis reinforcement or self-administration, cognition, food intake, sleep, and we also have a measure of pain because we know that cannabis can attenuate pain as well. So we're looking at all these effects. We've completed 1 very low dose, and we're currently testing another, so we're really excited about this compound. So just to summarize our efforts at medications development, in terms of relapse prevention, the winner for us is Nabilone. Again, it's a better medication than dronabinol. It's higher bioavailability, clearer dose linearity, longer duration of action. In terms of abstinence initiation, cannabidiol, no. Naltrexone looks promising and warrants further testing. And for AEF, it remains to be determined, but we're excited about that one. So I think I was able to finish up quickly, just take-home messages. Increased legalization, there's increased use among young adults, and daily use can become problematic and difficult to stop in patients who are seeking treatment. We currently have no FDA-approved medication to facilitate cannabis use disorder treatment, but we have important signals from the human laboratory that warrant further study. Importantly, research on cannabis use treatment lags substantially behind other drugs of abuse. So this, I think Yvonne touched upon as well. In terms of fully powered controlled trials, these are negative and these are positive. the majority, and Francis Levin, who is coming to speak here, has really led the field in a lot of these studies. Most have not worked. The only positive effect has been N-acetylcysteine, which we heard about, and that only has worked in adolescents for cannabis use disorder. It did not work in adults. And so just want to acknowledge all my colleagues in the Division of Substance Use Disorders at Columbia and the Cannabis Research Laboratory, and of course NIDA, who has funded me for a very long time, and I have received some funding from a family foundation. So thank you very much.